Give his presentation, and then after he's completed, we'll have a Q&A session for you, so please feel free to ask any questions. So I'd like to introduce Dr. Crane.
It's not fair to clap. You haven't heard the talk yet. Welcome, everyone. We're very appreciative that you came out. One of the things that has been very important to me over the years is not just to be a doctor and not just to do surgery and to take care of patients with arthritis, although that's the main focus of what I do. It's the opportunity to teach. And I think if we take that to heart, it's how we become better doctors. I'm not a native. I grew up in Tennessee, did all of my training in different sorts of places, wound up in Denver, Colorado, and practiced there for almost 27 years before I came here. I set up developed and ran a large joint replacement program in Denver. And out of the blue, got recruited to come here to set up and direct a joint replacement program at this hospital that had a very small program in the past, and it had sort of gone by the wayside. And my real impetus for coming here was that all three of my children that had grown up in Denver went to the East Coast to college and landed in Baltimore. So I came here to see my wife. It's been a terrific experience to come here. The people of Maryland are a lot more like the people of Tennessee that I grew up with than the people in Colorado. And so I feel sort of a special kinship to being here. And I thank you for coming. I hope that this is helpful. My plan is to make a presentation. We'll have time for group questions when we're done. If there's something that's just burning in somebody's mind while I'm speaking, if you have a question and you need to ask it, it's perfectly fine. But there will be a time for all of us for public questions, and sometimes in these situations, people want to ask something about themselves that they don't necessarily want to share with the group, and I'll be available here to speak to you as individually. I don't have a separate room to talk to, but if you're more comfortable in that situation, we can address that as well, and I'll be here to speak to you about it. Today's topic is about arthritis surgery, and particularly new things about arthritis surgery that are very pertinent and very important in what we do today. But to get started, I think that it's really important to understand what is arthritis to begin with. And arthritis is really only a generic term. And it means that the cartilage, the cartilage on the end of the bone of a joint has worn out. If any of us have ever pulled apart a chicken joint, that shiny white stuff on the end of the bone, that's the cartilage that we're talking about. That's called articular cartilage. Now, some joints also have a meniscus cartilage in it, and that has a different function. But the articular cartilage is the smooth bearing surface of our joint, and it covers the end of the bone here. And we have ligaments on the side of the joint, we have the bone, we have a lining tissue called synovium throughout the joint. And this is a graphic depiction of what a normal joint looks like. But when a joint starts to break down and develop arthritis, that cartilage surface on the end of the bone is no longer shiny. It becomes kind of dull and gets little irregularities and cracks in it. And that's usually when people start taking a little bit of Tylenol and sitting down a little bit more frequently. But the end result of severe arthritis is when that cartilage on the end of the bone is gone. Or if you think about it like a road, it's a road full of potholes, more potholes than asphalt. And that's what it's like. And for people in this room who have it, you understand why it's not smooth anymore. It grinds, it pops, and most particularly hurts because the nerve endings for the joint are not in this articular cartilage. They're in the bone right on the other side of it, and in the ligaments, and in the synovial lining tissue. And that's when it starts to hurt. But understand that surgery is only a small part of the treatment of patients with arthritis. We're here to talk about surgery, but in fact, surgery is always the last resort, and you'll hear this from me several times tonight. We want to focus in those patients with arthritis with medication, with exercise, perhaps formal exercise in the form of physical therapy, weight control when it's appropriate, and modification of daily activities. The goals of surgery are to relieve pain and to enhance and improve function. It's not purely for appearance. Some people are concerned that their leg is crooked or that they are not walking quite as well as they would like. It's not purely for appearance that we do this. Total joint replacement surgery is the most common surgery that's done for arthritis of the hip and knee. In the United States today, we are close to 1 million joint replacements a year being done of just the hip and knee. It's projected within the next 5 years that we may be doing between 1.2 and 1.5 million joint replacements in a year, and there is concern in the Orthopedic Society that there may not be enough joint replacement specialists to do it. Well, what is that joint replacement? It's actually replacing the surface of that arthritic joint with synthetic material. In some cases, like in the knee, it's kind of like a retread on a tire. And I'll use car analogies a lot because everybody's familiar with them. In a car, it's kind of like a retreaded tire. In a hip, it may be the entire tire that we replace. But we replace them with synthetic materials, and I'm going to just review some of them with you because they come up, and people ask often what they're made out of. Well, we have metal alloys. Some of them are space age, and some of them have been around a long time. Chrome, cobalt, molybdenum alloy. We're going to do a test in a minute and see who can say that. Again, I struggle with it, and I do it every day. But this is one of the mainstays, and the origin of this metal was actually from salt water turbines. And our body is a lot like salt water. And this metal was found, and it started out its use there and has been one of the mainstays in joint replacement surgery. Everybody's heard of titanium, and we compete with the aerospace industry and with the golf industry and a lot of other industries for the use of titanium. Most of the titanium that we use is an alloy to make it stronger than pure titanium, but there are times when we use pure titanium. And then there are some very fancy metals called tantalum and oxinium. These are more recent additions to what we use, and we don't use them commonly. We use them in special situations that are probably not pertinent for tonight because it's pretty detailed. The main bearing surface that we use is plastic. It is an ultra-high molecular weight polyethylene. Anybody know commonly a use of polyethylene that many of us see in our daily life? Milk jugs. Plastic milk jugs are made out of polyethylene. Now, that polyethylene is a low molecular weight polyethylene. It's not very strong. But this is an evolution of that very material into something that's very durable, very strong, and very resistant to wear. There are some joints like in the hand where we use silicone, and in all of these we use some variation of ceramic at certain times. Well, just a little example of some joint replacements. This part here on your left is a shoulder replacement. And this part here is a hip replacement with the ball and the stem and the socket. This is a knee replacement that's on a model simulating a normal knee with the ligaments on either side and the metal and the plastic between. And this is one of those silicone finger joints that I referred to just a moment ago. How do we hold these parts in place? Well, we hold them in place in a variety of means. The most common way we hold them in place is with an acrylic bone cement called polymethyl methacrylate. Oftentimes, we hold them in place with the very materials that the parts are made out of, and they are porous. And they're porous in a manner in which the bone actually grows into the parts. And then there are also some circumstances where those parts are coated with chemicals that enhance the body's ability to attach it to the prosthesis. On the left here is something that's sort of egg-shaped looking. That's a ball of this acrylic cement. And it's soft, and we put it into the bone, and we bond the parts to it, and it becomes hard. And on the right is an example of a part that is smooth and designed for it to be cemented in place. But on the left here is one that is porous coated. If you look at it, it's not smooth and shiny, and if you could look at it up close, you would see that it's porous and that the bone can actually grow into this surface. This is an example of a chemical coating onto a porous surface, and this chemical is called, it's actually a ceramic material called hydroxyapatite. And that's actually the mineral that's in our bone, and we're able to synthesize it, and in some cases put it onto a prosthesis, so when you put it in the bone, the surrounding bone thinks it's another bone and just yields to it, kind of like a broken bone yields. And there's certain circumstances in which this is a benefit. This is an example of a normal hip and an arthritic hip. I'll bet you can tell which one is abnormal. Normally the ball is round. There's a nice space between it. That articular cartilage that we talked about, that's the space. That's not air. That's the actual cartilage that covers the ends of the bone, and about half of it is connected to the ball, and half of it is connected to the socket, and it makes up that space. And this is what it looks like when that space is totally gone. And this is a hip that's very sore and very stiff because it's nothing but potholes. And this is a model of how we would replace it. And in fact, we cut this ball off and we put this ball with a stem that goes down the inside of the bone. The thigh bone is hollow, just like a chicken bone, except a little bigger. And we use that space to anchor our part. And this is what it looks like. This is that arthritic hip. And here's what it looks like with a hip replacement in place. And in this particular case, the socket is a porous material that the bone heals to. And in the stem part, this white fluffy stuff that's on the inside of the bone and surrounding the prosthesis is actually the bone cement that anchors it in place. Well, in a knee, that erosion can sometimes cause deformity. And that deformity is frequently a bow-legged deformity or what's called a knock-kneed or valgus deformity. And we've seen that many times. A normal joint looks like this with a symmetrical space on either side. And here's what it looks like when the cartilage is worn away just on the inside. And that produces a knock-knee, a bow-legged deformity, or a varus deformity in medical speak. And that's what it actually looks like. We've all seen something like that. This lady agreed to have her picture taken on the operating table right before her knee replacement. And this is what it looks like, that normal bow-legged deformity. And that's what it looks like after her knee replacement. Her knees are straight now. And this is what her parts look like. And that's the result, and she's very, very happy. And this is that knock-knee deformity. And it's a different kind of problem, but we deal with it in general terms similarly. And this is what that part looks like. This has got a little more metal in it, in this case a little titanium. And that's what it actually looks like in surgery. I apologize if it seems a bit gruesome, but it's what we do. And we shape the ends of the bone to fit these parts on it, and it results in a new knee. Everybody wants to know how long they last. Everybody's heard that hip replacements and knee replacements last 10 years. That was always false. But the early studies were done with 10-year follow-up, and they reported the results, and everybody thought that that meant that they last 10 years, and then they fail. That was never the case, but they have improved substantially since that misinformation got around. It depends on the patient's activity, their weight, the surgical technique that's done, and the actual parts that are done, that are used. Some parts have a better track record than others. And that's important because you want to make sure that if your doctor is using parts in you, you don't necessarily want the latest and the greatest, because they're not, they may be the latest, and in some cases they turn out not to be the greatest, and we're going to talk about that in a minute too. You want something that's been used for a minimum of 3 to 5 years and proved that it is durable. Well, in studies that were concluded over 10 years ago, over 90% of hips were functioning well at almost 11 years. Almost 93% of knees were functioning well at 11 years. With our modern devices today and the follow-up results that we have seen with those, it's projected that the average person who gets a hip replacement or a knee replacement over the age of 50, it may last them their lifetime. So the average modern hip replacement and knee replacement today may last 20 to 30 years or longer. I think to talk about advances. And so we've got a little bit of background about what the standards are, and now we're going to talk about what's new, because I think that that's on everybody's mind. Well, many of the advances that we have are related to the materials, where we have been able to improve the wear qualities of that plastic. That high-density polyethylene, we now have figured out that if we treat it with a certain type and amount of radiation, that we can improve the wear by 90% compared to the plastic that we had from 15 years ago. And those 90% that were still working at 11 years, those were the ones with the old plastic. And this new plastic we have had for almost 13 years, and it appears, at least to the naked eye, that there may be no visible wear on these parts today after 13 years of use, whereas before, at 10 years, about 50% of them had visible wear, although it was not bad enough to affect function or require further surgery. So this has been a tremendous advance. But the next item on this list, metal on metal, is one of those examples of why you may not want the latest and the greatest. Because all of you have heard the lawyers advertising for patients. If you've got this hip, you call us because compensation may be due you. Well, that's particularly related to these metal on metal hips. Now, when we started doing them, by all known testing, it seemed to be a pretty good idea. They were more resistant to wear, and with all of the testing that we had known to us at the time, it was a pretty good idea. And a lot of them were done, only to find out that at 3 to 5 years, they started failing much quicker than the parts that they had replaced. And some of them had designs that were distinctly poor, but all of them have subsequently failed or worn at rates higher than were predicted initially. And it's created a problem. So we have a lot of redo surgeries that we have to do today because of this latest and greatest that wasn't. Everybody's heard about ceramics, and there's a type of hip that is a ceramic ball and a ceramic socket, and the jury is still out on that. It's very, very popular in Europe. In the United States, having been kind of burned with metal on metal, we're really a little reluctant to adopt this because there have been some cases, a number of them, where the ceramic hips squeaked. I don't know if anybody's ever heard of that, but they actually developed a squeak and you could hear somebody from across the room. And that's, you know, you can't sneak up on anybody with that. So we're not so sure yet that the ceramics are an advantage. But a ceramic ball with a plastic polyethylene bearing in the socket has been outstanding. And that may even wear better than a metal ball with a plastic socket. But there's a very small risk of the ceramic breaking. So we don't do this on every case, and particularly we don't do it on our larger patients because of that risk of that ceramic breaking. And then ceramic coatings, I talked to you about the oxinium metal. There are a very small percentage of patients who are allergic to nickel and to some of the other materials that knee replacements are commonly made from. And these ceramic coated devices are the ones that we frequently use in those patients who are very sensitive to nickel. We have techniques that have speeded the recovery of our patients from surgery. 20 years ago, the average patient was in the hospital 10 days for a hip or a knee replacement. In fact, when hip replacements were pioneered in the mid-50s in England, the prescribed length of stay was 20 days. Well, we've done a little bit better today. And in fact, every few years, we have figured out ways that I'm going to describe to you to speed that recovery. One of them is surgeries that are less invasive. We've all heard about minimal invasive surgeries. It's kind of a marketing term, it's kind of a buzzword, but what it really means, which is valid, is that we have figured out ways to do these surgeries with smaller incisions, with different incisions that cause less injury to the surrounding tissue, that allow people to recover from their surgery faster. We have discovered something called preemptive pain management, and we're going to talk about that in a minute. We've been able to make our parts and the instruments for putting in the parts smaller and more precise, so there's less damage. We have parts now where there are many more sizes so that we can more customize the fit of the part to the patient. When hip replacements came out, there was just one size. And within 5 years, there were 2 sizes. Today, the hip that I use on most patients is 40 different sizes in order to more closely fit the patient's anatomy and the parts that we're using in order to restore that patient closer to normal. We even have parts that are gender specific. About 10 years ago, a company had a really good idea to come out with parts that were made specifically for women. And early on, some of the companies kind of poo-pooed it and said, oh, you're just marketing. But in fact, we know that women's knees and women's hips are not just smaller than men's, but they're actually shaped differently. And medicine, just like politics, just like business, has been prejudiced against women. Well, we're learning that we need to address those differences not by just trying to adapt the parts that were originally designed for men, but to design parts that are specifically designed for what's unique about women. We have the computer, and we've used these extensively to help plan a surgery, to help plan the parts, to design parts, and I'm going to talk about those in just a moment. We have care plans for taking care of patients. We have seen that when patients are taken care of in units within hospitals that specialize in joint replacement, patients do better because everybody understands more about the unique needs of those patients. We have programs to get people up. My average patient today with a hip or a knee replacement is up walking 2 hours after surgery. We call that fast track. But 2 hours after they get to their room from the operation, they're up walking. We have new strategies to help control pain. And this has helped dramatically as well. This is one of the reasons why people can walk. So how do we do that? Well, I'm going to tell you something that sounds very counterintuitive. We have actually focused on treating patients' pain by using less narcotics. We are learning, and people are hearing about daily, the problems of opiate addiction. Well, guess what? It's not good for you. We use them, we have to use them because in certain circumstances, for short-term use, there's nothing better. But we have figured out by various means of anesthesia and other kinds of medicine, we refer to it as multimodal, and we kind of attack the various pain centers around the body with numerous different types of medicine and only use the narcotics when they're absolutely necessary. And we find that the less that we use, the better people do. We have pumps that are sometimes used to put numbing pain medicine directly into a wound. And that this has been very helpful. And this has evolved to injections that we sometimes do. We call them periarticular injections, and we have long-acting medications that are not narcotic that we inject around a joint that we've just done surgery on, and the patients hurt substantially less. And they can get up and they can move and they can recover and not have the complications of excessive bed rest. I will tell you today, if you're sick, the worst position for you to be in is horizontal. The quicker you can get vertical, the less complications you'll have, the less problems you'll have. So we don't get you up to just teach you to walk. We get you up to avoid a lot of those complications that being in the bed causes. We thought that people needed to rest. Well, we figured out long ago when you have a heart attack, the worst thing to do is to lay in the bed. That patients after heart attacks, when you get them up to exercise right away and to do certain types of activities, it dramatically improves their recovery. We were wrong. The same thing with ulcers. We thought it was spicy food. It really wasn't. It was a bacteria that caused ulcers. And so we have evolved in our treatment in ways that have really helped. And we even have special treatments today for patients who have been on opiates, who have been on narcotics for long periods of time. Those patients are very resistant to pain medication. Their body has turned off the ability for these things to work, and doing surgery on these patients is very, very problematic. And we have certain types of treatments and certain types of medications which allow our pain control to be better in those particular patients. And all of these together have helped dramatically. The success is not in any one stroke of genius, believe me, it's in the details. Well, for minimum invasive surgery, we talk about little incisions, but what we've learned is it's not really the size of the incision on the outside that matters, because incisions this long heal just as fast as incisions this long. It's what we do on the inside that matters the most. And so we have learned, even if we need to make a bigger incision than the very smallest on the outside, if on the inside we cut less muscle or no muscle, and we cut less tendon, and we cut less bone, we're causing that patient less trauma to recover from as they get better from their surgery. And this is what minimal invasive really means. When you take away all the marketing and sales, it really means we are learning how to do surgeries that are less traumatic to the patients. One of the current fads today, one of the current buzzwords is the anterior hip. Probably many of you have read about it, you've heard about it. It's not bad, but it's also not new. It was developed by a British surgeon by the name of Smith Peterson in 1905. But we popularized it by doing it in a little smaller incision, and we've now called it the direct anterior hip. And theoretically, it makes a lot of sense. We go between the muscles, there's less trauma. It was hoped because of less trauma, there was less chance for the ball to pop out and there'd be a faster recovery. But what we actually found on these studies, there's little evidence to actually prove that that's the case. In fact, if a surgeon has done less than 50 of them, as proved in a study in clinical orthopedics in 2015, that the chances for complications are actually substantially higher, because technically it's a harder operation to do. What we found out in a study that just came out in the Journal of Arthroplasty this year is that anterior hips have a substantially higher rate of revision or failure within the first 5 years. This is the first time this information has become available. We're looking into it to see if we can figure out why. but it certainly is of note. Once again, latest is not always greatest. The alternative is the posterior approach, and it's certainly the most common. We've modernized it by calling it the mini posterior approach. But what we're doing is making our cuts in the bone, in the muscle, the ligaments, much smaller on the inside. It has clearly shown to have less bleeding than the anterior approach. There are some studies which have shown that the anterior approach has a little quicker recovery in the first 3 to 6 weeks. After that, no study has shown any improvement beyond that. And when that improvement is measured, patients discard their crutches or walker approximately 1.2 days sooner than with a posterior approach. So what we're talking about are measurable improvements that are statistically significant, but they're not earth-shattering in the improvement that they have. Most studies show equal performance, and the only studies that show fewer complications with the anterior approach is when it's done by a high-volume surgeon, somebody who does more than 250 a year. Those do just as well and have just as few complications as the high-volume surgeons who do posterior approaches. So what does that mean? That really means that you want to choose a high-volume joint replacement surgeon, not just any orthopedic surgeon. In the United States, the average orthopedic surgeon does 20 to 25 joint replacements a year. You want somebody who does a lot more, and that matters. And in fact, if they're a high-volume surgeon, it doesn't matter if they do an anterior hip or a posterior hip or a lateral hip. They function the same and they do just as well. How does the computer play in? Well, the computer has played in some very interesting ways. We have used the computer initially to help us plan the operations. And so in the past, we used to just sort of put up the films and we had some outlines of the parts and we kind of matched them up. And now we're able to do that with a computer. It's much more precise. But to take that further, we've actually been able, in some circumstances, to use the computer to help us do the surgery, to help us line up the leg, and we call that computer navigation. We also use the computer to help us plan the parts and the sizes that we use. And we actually design instruments that are sometimes used that are unique to the patient. And they use off-the-shelf parts that are optimized in their fit, but instruments that the computer has helped us design that are unique to the patient. And it all sounds fantastic, except the long-term, there are really no long-term studies, and the short-term studies have not shown clear benefit. We're beginning to understand why that's the case, and I'll talk about that in a minute. Been shown to be more precise. They are more precise than the free human hand. Most of the studies right now have not shown that that is an advantage, but it certainly, in only a very small number of cases, has been a disadvantage. We use a CAT scan or an MRI to help us. We use the computer to take that data and plan the operation and actually use the robot to guide our hand when we do this operation to be more precise. And it definitely is more accurate. It allows us to use smaller instruments, so we make smaller holes sometimes. The parts fit better. But using the robot has a downside. It's substantially more expensive. And there's some unique complications that have occurred by using the robot that didn't exist prior. We've gone a step further. And in fact, the latest technology, which we're the most excited about, which we are beginning to do at this hospital, is we are using the computer not only to plan the operation, to design the instruments for the operation, but to actually design and manufacture the parts unique to the patient's size, shape, gender. They're made individually for the patients. They're not off-the-shelf products like all of the other technologies use. They're made exactly to the patient's unique anatomy. They are using a special type of alignment for the parts. We refer to it as kinematic or anatomic alignment, as opposed to what we used in the past, which was called a mechanical alignment. And we can talk about it if you want, but basically it's putting the parts in a unique position for the patient's own anatomy instead of putting it in at a pre-described position. And we think that that's one of the reasons why the original computer navigation didn't show improvement, because they were very precisely putting the patient's parts in this mechanical alignment, which was the real reason why the patients didn't get better faster. The anatomic or kinematic alignment is now being shown to be much quicker in recovery because the parts are going in unique to the patient's anatomy. And the companies that are beginning to do this have figured out how to do it at no extra cost to the hospital or to the patient. So the parts actually cost the same as the off-the-shelf parts. So this is really something unique in medicine, that we've actually come up with a new technology that is unique to a patient's own anatomy, and we're actually able to do it at the same cost. It hasn't been around long enough for us to determine if it's going to last longer, but in the short term of in excess of 5 years it's been around, the results have been better, and patients have felt that their hip or their knee particularly felt more natural, more like a normal joint. So we're very encouraged by this. In summary, arthritis surgery is reserved as the last resort in most cases. Arthritis is not like cancer. God forbid if you get cancer and somebody says you need surgery, you need it now. Because if you don't, the surgery may not help you. Arthritis affects our quality of life. It affects our mobility. It causes pain, but very, very rarely is it fatal. We may feel like it's killing us because we can't golf, or we can't walk, or we can't put on our shoes, or sleep through the night. And granted, those are serious problems. But we don't want to recommend surgery until we have tried all of the reasonable non-surgical options, because we don't lose anything by waiting. And sometimes we find combinations of medicine and modification of activity and exercise that makes people's pain better enough that they don't feel that they need the surgery anymore. And that's always good. However, when it's appropriate, joint replacement surgery can absolutely change your life. Many people feel like it's a new lease on life. I refer to hip and knee replacement surgery often as the closest thing to magic that we have in modern medicine in terms of restoring people's life and quality and function. The best quality of joint replacement is provided in institutions that specialize in it. that have specialized joint replacement programs with surgeons and nurses and anesthesiologists and teams that do this as a special effort. And our advances in this area continue to improve. So sometimes waiting lets you wait for something that's better. And now you have something that has an outstanding 5-year result. And you can get it instead of having had that surgery last year. Now there's new information that shows that an emerging technology is truly better, or perhaps is not as good as we had hoped for, and we avoid the problem that we have had with the metal on metal and the recalls and the lawyers, etc. So I want to thank you very much for your attention. I hope that this has helped and raised some questions in your mind, and I would love to be able to take those questions now if you would like. I'm going to be really fair about it. I'm going to start at the front from either side and work to the back. So I know a lot of people who are interested in hip and knee replacement also have sore shoulders. So everybody in the back, don't raise your hand the whole time or your shoulder's going to get sore. I'm going to go from the front to the back, but I promise you that I'll get to you. You were first, sir.
Yes, sir. Has any work been done looking at replacing just the cartilage without putting a new knee bone?
That's a great question. Has any work been done at replacing the cartilage? Yes. We have developed some techniques where we can grow cartilage in a test tube. In some very isolated circumstances where there's a single pothole, we can fill that pothole with that cartilage, and that has worked fairly well. The problem is it's usually the result of a traumatic injury, and it's usually in a younger person. The older patients don't tend to have a single pothole, have a whole bunch of them, or they have a bare spot, and those technologies have not been successful for that. There is some emerging work being done with stem cells. When those studies have been subjected to scientific scrutiny, that is being done at multiple centers, it has not been as promising as we had hoped for. But I think that the majority of the work today on creating cartilage replacement is in that arena. Sir. Oh.
I was going to ask about alternative treatments. Do you ever do hyaluronic acid injections?
So in terms of alternative therapies, do I ever do hyaluronic injections? We euphemistically call them chicken shots or gel shots. What they are, it's actually a substance that is like the cartilage, that articular cartilage, and it's derived from rooster comb in most of the cases, and that's how we got the chicken shot out of it. But it provides a lubricant for the joint. And we were very enthusiastic about that a number of years ago. The longer we do it, the less enthusiastic we are about it. We still believe that it has a place, and the most effective place for it is in patients who have not lost all of the cartilage yet, because this seems to help and nourish and lubricate the existing cartilage, but when it's down to bone, it doesn't work very well at all. So it definitely has a place. We're a little less enthusiastic about it today than we were 3 or 4 or 5 years ago. It doesn't seem to be holding up extremely well. It still has a place, and we still do it.
So do you recommend a series of exercises and stuff to get tendons and muscles ready before surgery?
Absolutely.
You have a program that you...
She asked, do we have a series of exercises that we do for patients before surgery, we have some exercises that we recommend for patients to do, hopefully instead of surgery. And when that doesn't work and surgery is decided upon, some exercises that we recommend that people do in order to speed their recovery. So we refer to that euphemistically as prehab. Rehab is sort of after the fact. It's sort of like studying for the test after you got your grade. So it's a lot better to prepare beforehand. Sir?
So I imagine, you have to, for a knee replacement, you have to, take off some of the bone, prepare the surface. And so I imagine that if you have to do a knee replacement more than once, you have to take off additional, you have to prepare the surface again so that removes additional bone. So there probably is a limit on how many knee replacements you can feasibly have. So what sort of number would that be?
The question is there a limit to how many knee replacements you can do? Yes. Every time you have that knee replacement or hip replacement, more bone is lost. And the bone is kind of like the foundation of your house. If your house gets hit by a hurricane or a tornado and the house is destroyed, but the foundation is strong, you can build a new house on it, it'll be just like a new house. If the foundation is flawed, a brand new house will fail. It will leak, it will crack, it will cause problems, and it will not function normally. The same is true in joints. We have joints that are designed to be used only in redo cases or revision cases, so that they accommodate certain losses of bone and losses of structure. We have ways when we do revision surgeries to rebuild and augment lost bone. Sometimes with bone from someone else, usually who wasn't wearing their motorcycle helmet, or from yourself, or with synthetic materials and sometimes special metals. So we have a lot more flexibility than we had 10 or 20 years ago, but there is always a limit. And sometimes what is mechanically possible isn't always in the patient's best interest. So if a patient has severe medical problems and heart problems and vascular problems, you could wind up doing a very successful surgery that kills the patient. So we have to be aware and also be willing to say, this is mechanically possible, but it is not what is best for you for those reasons. So we have to be willing to do that, but we have to be willing and able to explain it to our patients in ways that they can understand, not just, you're not a candidate for this, get out of here. Yes, sir. Oh, I'm sorry, we're close by, so we're gonna go here with the mic, and then we'll come to you.
How can you provide somebody that when it's the last resort? I mean, if somebody's very tolerable, and just puts up with things, when does somebody make a decision saying, hey, it's time? That's
a great question. When is enough enough? How does a patient decide? Well, hopefully the surgeon, the doctor has explained to them some alternatives, and that the doctor and the patient are sufficiently convinced that those have been adequately pursued. I tell my patients, you will tell me when you've had enough. You'll come back in and you'll be waving the white flag of surrender and say, I tried everything that you said, it's not working, will you fix me? And my answer will almost always be yes. it's a personal decision. It's a quality of life decision in most circumstances. For you, I'm not picking on you, for you it might be that these alternatives have not allowed you to get back to playing golf. And that's really important in your retirement, in your quality of life. For somebody else, it might be that they can't get out of their wheelchair, off their walker, or put on their shoes and socks anymore. It may be as significant as that. It's something different for everybody, which is why we relate it less to a specific event than to a subjective quality of life. Does that make sense? That's really how we decide. It's not totally black and white because it's different for everybody. Now there's some actual mechanical problems. For example, in somebody with a knock knee deformity, where you can actually wait so long that the joint is damaged enough by the deformity that I can't fix it as well. And so I will help people understand that these are some actual mechanical guidelines that we need to consider as well. And if we cross that threshold, even if your knee is not, or your hip is not killing you, it's not bad enough to ordinarily recommend surgery. If we don't, it may not be able to be fixed as well. And so we occasionally will invoke that criteria, but most of the time it's completely subjective. Yes, sir.
My question was Invasive, but also was wondering how many surgeries, how many joint replacements do you do in your center per year?
Well, in our center currently, since I'm here, we've increased from about 250 to about 600 a year. I come from a practice experience where I did 600 a year myself. In the last 30 years, I've done about 7,000 hips and about 7,000 knees. And that is certainly in contrast to the average orthopedic surgeon who does 20 or 30 a year. And I'm not smarter than that person, but I am a lot more experienced in hip and knee replacements. And I think that that's the important thing. This is not about being smarter or better or whatever. It's about being more experienced. And that's the reason why specialty centers make a difference, because they are more experienced and they are more focused. And it is absolutely appropriate for you to ask your surgeon how many of these you do a year and how many of these have you done total, because it matters.
Okay.
Yes, ma'am.
Is joint replacement contraindicated in a patient with osteoporosis?
Is joint replacement contraindicated in patients with osteoporosis? The simple answer is no. The techniques that we use in the face of osteoporosis can sometimes be different bone. It would be most common to put those parts in with a device that didn't have cement, because the bone is strong enough to hold it and it works well. In somebody whose bone is thin or weak and osteoporotic, we would use bone cement to augment that, and that works just as well in that particular patient as the uncemented one does in the patient who has good bone. There are some extreme cases, but they are very, very extreme. Yes, ma'am.
What are the thoughts of having both knees done at the same time?
What is the thought about having both knees done at the same time? There is some controversy about that, and there are a few surgeons in the country who do it enough and who do it quickly enough that it is not a significant factor. However, for about 99.5% of surgeons in the world, including me, if you do 2 at the same time, your chances of developing a significant medical problem are 30% higher than if you do the surgeries sequentially. And sequentially can be as close together as 4 to 6 weeks. But if you do them at the same time, and numerous studies have shown, even in surgeons who are really fast from very high volume centers, the overall percentage of patients who have significant medical problems is 30% higher if you do them both at the same time. What I have found in my personal experience is the overall recovery time is also longer than if you do them sequentially, because when you do 2 at the same time, it's not twice as hard. For the first month after surgery, it's 4 times as hard. And patients get behind in their rehab, and if they're trying to rehab, for example, 2 knees at the same time, neither one of them can get the attention that a single knee gets. And so studies have shown in some cases that the overall results of those patients is a little bit less than in patients who had them done sequentially. There are unique circumstances in which we do it in any case, because if a patient were very young and very healthy, it's 30% of a very small number. So it's not a substantial increased risk. Or if you have somebody who has a job situation that can be out once and longer than twice and shorter, then you have to at least consider accommodating a situation where a patient's not at risk for losing their job. There are those special considerations, but in general, I really try to discourage it.
When you say medical problems from that, do you mean like risk of infection?
Risk of infection, risk of bleeding, risk of blood clots, risk of fracture, risk of nerve damage, risk of heart attacks, strokes, unplanned ICU admissions. These are the list of medical problems associated with bilateral simultaneous surgery that is increased by 30%.
I guess I had a different question than what you've been getting. Back in August of 14, I had my right knee replaced. It'll be 3 years this August, and it's still not feeling right. In the meantime, my left one has gone bad, and it's really bone on bone. And I'm afraid to get it done. So I don't know what to do. I feel like, they took another x-ray, and that showed everything was okay. And so I don't know what the problem is. The whole right side of my right leg is still very numb. And then if anything rubs against my knee, it hurts. It's very, very sensitive. And I don't know what else to do. And the left one, I'm walking terrible. I'm one of your not-knee patients and walking terrible. And I just don't know what to do.
So this lady has presented a very difficult dilemma. First and foremost, get a second opinion, because if the surgeon who did the first knee says that there's nothing wrong with it, doesn't mean that that's absolutely true. There may be some subtle abnormalities that explain why that knee is not functioning the way that you had hoped for. On the other hand, it may be an example of a circumstance in which The surgeon just didn't explain to you that a knee replacement is not like a normal knee. And it's very important to understand that. And there's a lot of patients who are not happy with their joint replacement because they expected it to be the knee that they had when they were 20 or the hip that they had when they were 25, and it's not. It's still artificial.
Should I be able to kneel?
At least 25% of patients who have a very good knee replacement that they're happy with still have pain when they kneel. There are reasons that it can be a problem, and there are some reasons in which it is the normal consequence of having a knee replacement. So you're in a little bit of a pickle because you've got the other knee to do. And I think that what you're saying is that if the other side turns out the same way as the one that you've got, you might not be willing to do it. Is that accurate? That's the real problem. So you want to find out from a specialist who's done lots and lots and lots of knee replacements and lots and lots and lots of knee revisions. A specialist who can sometimes see subtle abnormalities that the average orthopedic surgeon might not recognize, and it's an experience thing. It's not a brain thing. It's an experience thing. There are subtle abnormalities that I see in a knee replacement or a hip replacement today that I didn't even recognize in the first 1,000 that I did. I just thought that they were fine and the patient hurt, and that sometimes that's just the way it is. And it still is sometimes just the way it is, but not always. I hope that that helps. And I sympathize with your dilemma because it's a real dilemma. But it may have a solution.
Thank you.
We're going to go to the back before we come back up to the front, just to be fair.
What are the effects of taking Actonel for bone density have with knee surgery?
What are the effects of Actonel for bone density for knee replacement? Essentially none. As long as the Actonel doesn't cause you gastrointestinal problems, esophagus problems. There is also a unique complication that class of drugs can cause, which is a brittle bone problem of the femur, and is a recognized complication of spontaneous fracture of the middle of the thigh bone on patients who are on those drugs for more than 3 years. So that needs to be monitored very, very carefully. And there's also an alternative condition where the jawbone collapses as well on patients who are on that medication. So it needs to be monitored by somebody who knows that and is looking for that particularly. In general, for most patients, it reduces their risks of fracture and is a very worthwhile thing to do, but it really doesn't impact a knee replacement at all.
I considered getting the cold radio frequency knee ablation treatment, but I'm concerned that it does kill some of the nerve cells in the knee, and that it would only last 6 to 12 months, the relief. What are your feelings on that?
It is far from mainstream. It is not an acknowledged strategy for dealing with osteoarthritis as far as our certifying bodies are concerned. It has not been done long enough to know what the long-term positive or negative effects are. And if somebody tells you that they know what they are, they're lying. It doesn't mean that it might not help you and be effective, but there is no substantive literature to support more than a very short-term benefit. And there's no long-term data to help us understand if it could be a problem. Now, in that context, everybody's familiar with arthroscopic surgery, scopes of the knee. We are just now beginning to get data that shows that some arthroscopic surgery of the knee may increase the rate of arthritis and increase your likelihood of developing it and needing a knee replacement sooner rather than later, even though the idea was to delay it. We are now beginning to understand that the opposite may be true, and I say that in the context of your question. It doesn't mean that in certain circumstances it may not be helpful, but anytime you burn a nerve, anytime you reduce the protective sensation of a joint, you're not only affecting pain, but you may be affecting a protective mechanism that is in place to tell you you're doing harm. I don't have a definitive answer for your question, but I wanted to sort of think out loud so that you understand a way to at least think about the therapy, the treatment. If somebody, I know somebody up front had another question, we can answer that. And if there are no other questions that people want to talk about in front of the group, but may want to ask me directly or personally, I'll be up here afterwards and I'll answer everybody. Sir?
Are your prequel exercises available?
Are our preoperative exercises? Typically, what we do in those cases is we refer patients to a group of physical therapy places in the area that have learned that specifically what we want to strengthen. So we focus on core exercises, sort of your strength muscles that go between your rib cage and your knees, so that your back is more stabilized and you're able to use your lower extremities better. We focus on your walking technique. We focus on your upper extremity strength to help you get up out of a chair. They're not secret things. They're more things that we focus on to achieve certain performance goals after the surgery. So when we write that prescription, it focuses on those specific things to physical therapy. But I will tell you a little secret, it's not a secret anymore, that one of the best things that you can do to reduce your likelihood of needing surgery or to prepare for surgery once it's inevitable is to get in the pool and to walk in chest deep water. It unloads your joints, it focuses the strengthening on your core and all of your walking muscles. And if you're a lady, you don't even have to get your hair wet. That matters. It's another 30 or 45 minutes that you've got to deal with when you get in the pool if you get your hair wet. I have girls at home, I know. But if there was one thing, that's what I would recommend. Yes, ma'am.
When you use the computer created parts, are they made out of plastic like these?
The computer made parts that we use to put into the knee are made out of exactly the same materials that our off-the-shelf parts are. The same metals, the same plastics, and so forth. The instruments that we use to put them in with are actually made out of plastic. And they're disposable.
What is your opinion on stem cell?
What is my opinion on stem cell? I believe that it is an emerging technology. Some of the other techniques that we have tried have not been widely successful. Stem cells theoretically have some real potential advantages, but the uses of stem cells today for arthritis have not shown very promising results yet. And to do it is pretty expensive. It's about $5,000 to $8,000 per treatment. And the people doing it don't give you the money back if it doesn't work. There clearly are some circumstances in which it has, but they're not widespread.
How long have they been doing it?
Some work in stem cells has been done for the last 30 years. As it relates specifically to arthritis, probably the last 10 to 15 years, and more intensively in the last 5 to 7 years. There's kind of been a commercialization of it that's a little bit distasteful because people are kind of selling it like snake oil and it's not that good. But it's not all terrible. It just hasn't held up to scientific examination in multiple centers. That's how you know something really works. It's when somebody who doesn't have a financial interest does it and it works.
What are your thoughts on dry needling along with physical therapy?
So this is a great question. What are my thoughts about dry needling as a part of physical therapy for the hip? Dry needling is an interesting thing that I'm not sure that I understand how it works, but literally a trained therapist who knows where to put these needles will stick very, very skinny needles that are like acupuncture needles into certain areas around an affected joint. And I have seen it in many cases be extremely effective when nothing else worked. There's very little downside except getting poked a bunch of times with a skinny little needle. And you know, the redness and the soreness that sometimes happens from it. But I thoroughly endorse it as an option to try when some of the other things for therapy have not worked. I've seen it work when everything else failed, and I've seen lots of times where it failed also, but there's virtually no real downside to it. Yeah, it helps. For the people that it helps, they will say, nothing else helped me and this just turned off the pain. It really, really worked. And they're very enthusiastic about it, and I'm actually enthusiastic about it. If I get somebody that I prescribe conventional physical therapy for, and it doesn't work, and dry needling has been helpful in other cases for that specific problem, there are a few people in the area who do it, and I know them, and I say, go see this guy or this person, and have them try this because sometimes it works when nothing else does. How many more times are you going to do it?
Well, I'm at the point now where now the doctors are talking to me about replacing the knees. I'm bone on bone in both knees.
Sure.
And I try not to use my chair when I'm at home. I like to walk in the house as much as I can, but the pain is horrendous. But when I'm out, I have to use the chair because I've done fallen too many times, and it's
Sure.
not a good feeling.
Well, I'm going to use your experience to talk about something that you brought up, which is not that chicken shots sometimes don't work, but the role of steroids, because they're commonly used. And what people don't understand, and we are beginning to understand in published scientific series of studies, that if you have cortisone in your hip or knee prior to a hip or knee replacement, your risk of developing an infection in that joint replacement is substantially higher for up to a year after the injection for hips and up to 3 to 6 months for knees. It is a double-edged sword. Sometimes they're wonderfully helpful and we use them frequently, but sparingly for that reason. They are not benign. They can definitely be one of the tools that we use, but there is some risk associated with it, so you have to be aware of that.
So what, if I understand you correctly, doctor, is this: if I am scheduled to see a physician, let's say in October, to take a look at my knees and make the determination that it's time for surgery, then I should not have any injections at least 3 to 4 months prior to this.
3 to 6 months prior.
3 to 6 months.
Absolutely.
Okay. All right.
If you came to see me and you'd had a shot within 3 to 6 months,
You'd say bye-bye.
no, I'd say we're not even going to consider surgery until that amount of time has passed. Because there are very, very few complications of joint replacement surgery that are worse than the complication of infection.
Very good. Thank
It's a
you.
disaster. So we have to do everything to reduce that risk.
What would be the length of time you would tell me to wait? I had the cortisone in my hip, so how long should I wait for that?
6 months. The literature says 6 months if somebody does not have other infectious risk factors. 3 months for knees if you don't have other risk factors. If you have diabetes and you have vascular problems and you have had previous staph infections, double both of those times. 6 months for knees and a year for hips. In the back, sir.
Last month, I had cortisone shots in both hips, and in 10 days, my left hip has started aching like a toothache going quick. Today's my best day in, I don't know, a month and a half. I'm scheduled to see you 2 Thursdays from now, and you just said I would have to wait a year before you could do anything with my hip if I'm a candidate for a hip replacement.
Well, at least 6 months.
What do I do about the pain? I don't want to go the opiate route. And what do I do? I mean, the pain is like, once I hurt it, it doesn't stop till I fall asleep at night and wake up the next morning, and I still have like a dull ache. And if I start moving around, well, what do I do about that for a whole year or 6 months even?
Well, we'll explore what you've done previously and see if there are some other non-surgical options, perhaps some activity modifications, some footwear changes, some lifestyle things to temporize the situation, perhaps some specific exercises that can be helpful, sometimes some weight loss can be helpful. We will do everything to try to temporize the situation with the use of opiates as an absolute desperate option if you can't do anything else. But again, as something that I would consider as desperate and not something that I would encourage. It's a rough problem. It is a dilemma. It is one of the downsides of injecting a severely arthritic joint with cortisone. If you do, you're stuck. If it doesn't work, if it works, great. But if it doesn't work, you're in limbo. It's a problem. But still, I wouldn't do the surgery prematurely.
How about, I have AFib. And on my knee, and I was just wondering, I'm almost 90 years old, so there would be any problem of replacing that knee?
Would the heart condition of atrial fibrillation or AFib prevent somebody from having a knee replacement? No, not at all.
Good, good.
We do it every
Now, I
week.
plan on having it done maybe in 6 or 8 months or
Sure.
something.
There are different protocols for dealing with it, depending upon the medicines that you're on and the cause of the atrial fibrillation. The way we deal with it around the time of surgery can differ a little bit, but it's an issue that we face every week because it is such a common problem. Well, yes, ma'am.
With arthritis in the knees, do the legs and the feet have a tendency to swell up?
With arthritis in the legs, do the legs and feet have a tendency to swell? It's very common. Oftentimes, the swelling in the legs associated with arthritis, if it is generally in the legs and generally in the feet, is not because of the arthritis, it's because of the inactivity that the arthritis has caused. Well, thank you all very much for coming.
Yes.
If anybody has any specific questions that they would like to ask me semi-privately up here, I'm glad to do so. But I really appreciate your attention and your questions. It always energizes me to see people who are
Thanks for
interested in this sort of thing.